My name's Dr. Alex King. I'm a consultant oncology radiologist based at the University Hospital of Southampton, which is on the south coast of England. I've been a consultant there since 2014 and was there beyond prior to that as a resident. I have a specialist interest in image-guided cancer ablation and spend most of my clinical and non-clinical time involved in that field. So I predominantly treat solid organ cancers. The main focus of my work is on renal cryoablation and liver microwave ablation. My work in the liver includes both primary liver cancer, so HCC, and metastatic disease, and increasingly that includes more and more colorectal liver metastases based on the collision trial data. I also have a small, rather niche practice where I treat prostate cancer with cryoablation in the MRI scanner. I began liver microwave ablation probably about 13 or 14 years ago now. And at that point, it was very much we were treating primary liver cancer more than metastatic disease. So hepatocellular carcinoma, primary liver cancer was the majority of the work that we did. It's changed an awful lot since I began learning how to do it. In the beginning, it was very much an operator-dependent procedure. The outcomes were largely down to the experience and the skill of the person holding the probe and directing the procedure, rather than anything else. And early on, it became clear that we needed to do this a little bit more objectively. And so I happened to be using some software, some fusion software in my diagnostic work for PET reporting or radiotherapy planning. And I thought we can take this into the CT scanner and use this for the ablation work. So we very quickly started to use it to merge images together rather than just looking at them side to side to work out whether we'd put the probe in the right place or whether the ablation had been adequate. So that was the sort of very early part of us using fusion software. And over the following 10 years, that's really developed into something that's become mandatory in our practice for every liver ablation that we do, not just for HCC, but increasingly for metastatic disease, and has become something that not just us in Southampton, but people across the world have come to the same conclusion that we need to use software more and more. And predominantly that's allowing us to create a much more standardized procedure, which is more predictable, more reproducible, and also something that we can get the really very best out of the microwave equipment. So it's changed dramatically, really, over the time that I've been involved, from something that's very operator dependent to something that's now becoming much more prescribed and reproducible and dependable. The evidence at the moment is really exciting. We had the collision trial data that told us really that ablation for colorectal liver metastases is at least as good as surgery. And now we've had data such as the coverall study telling us kind of how we should be doing that ablation. So coverall in particular was about using automated software to determine the efficacy of your treatment at the time of doing the ablation, and compared the patients who had software used and those who didn't have software used and had a traditional two-dimensional visual assessment. And the evidence during the trial was so strongly supportive of using software that they abandoned the other arm and really just went with the software. So we know that to get the very best out of microwave ablation, we need to use three-dimensional software analysis in order to determine whether or not we've had an adequate treatment. And coverall is one example of several studies that are beginning to show us how best to do ablation and how to standardize that intra-procedural decision-making. The ACCLAIM study is going to be really important for all of us. We're expecting it to tell us that for colorectal liver metastases under 2.5 centimeters, to get the very best results, we should be using software to confirm the margins of our treatment at the time of doing the ablation. And the important thing about ACCLAIM is that this is now a multinational, multi-center study that should really help to drive the standards that we should be achieving with ablation, and again, tell us how we should be measuring our success at the end of the treatment. So I think the next step is actually really exciting. I think what we're getting to is we're now understanding from the data exactly how these procedures should be done and how we should measure our success. And what we then need to do is to move that process to every center that's doing thermal ablation, not just being able to say that the centres of academic excellence that publish their work are able to get great results. But actually, we've now produced a process that, if it's followed in a particular way with particular equipment, you can get the same results at any centre. So I think the next thing would be to introduce that across multiple sites and then collect that data to prove that we've really nailed how to do this well. So from my own personal perspective, using software for confirmation has been part of my practice for a long time now. The new thing that's happened for me with my ablation guide has been the ability to do peri-procedural planning. In other words, at the very beginning of the procedure, we can now determine where the probe is going to be placed, how big the ablation needs to be, based on the position of the patient and the parameters of the scan on that day. Rather than having to do it the night before on a scan from 3 or 4 weeks earlier, we can pretty much do it live. So that's been the new thing for me, but actually the learning curve to introduce that was very, very small. A handful of cases, and we were ready and able to do that. I obviously have a background with using software, which has been a massive advantage, but I've seen with our trainees and our fellows and even our experienced nurses that actually they've been able to pick up the software and use it very quickly. Within a handful or less than 10 cases, most people are feeling reasonably competent and confident to run it through a case. In this particular iteration with my ablation guide, the new step is for me to be able to do the planning during the procedure without having to do it the night before or the day before on old imaging. I can now do the procedural planning in terms of where I'm going to place the needle and how big the ablation zone needs to be on the direct live imaging that we have with the patient already asleep in the CT scanner. My ablation guide works so quickly and easily that we can do this in effectively real time. And so instead of just having to confirm where the needle has been placed and whether the ablation zone is adequate, we can now go back to the very beginning of that stage and say, how do I want this to look? And how am I going to produce that outcome? So from my perspective, this is now a kind of complete process that's integrated with a single software package that leads me from the beginning to the end in a very clear and concise way. That means I can assess how well I'm doing objectively, as well as produce some evidence that I have reached technical success at the end. My general advice has always been and will remain that don't wait until you think you need this software. It's there, it's available, use it for every single case. Make sure that the team know that you're using it and that they understand how it's used. From my own personal perspective, we have trained a nurse to be able to use a lot of the software on our behalf. So they have our oversight, but they are doing the manual processes so that we can stay sterile, we're still scrubbed, and they can do the segmentation of the tumour or the fusion itself with our oversight. So that also brings in other members of the team to be more involved in the procedure, to be able to be a little bit more objective about it and say, or be impartial about it and say, actually, Alex, are you sure the needle is where you think it is? And exclude some of my own, perhaps subconscious biases into the procedure, that it will improve the outcomes too. My experience with the IntelliBlade microwave system has been very positive. The thing that really makes a difference for me is how predictable the ablation zone is. So I've spent a lot of time talking about how I'm impressed with the planning process, but that's only as good as the execution. And we're really seeing that the ablation zones are the size and the shape that we were expecting based on what was prescribed from the planning. So the standout feature so far for me with the IntelliBlade system is the predictability of the ablation zone. When we place the needle where it's supposed to go and we prescribe a time and a power for the needle to deliver, we end up with a nice spherical ablation zone that matches exactly what we wanted. That is more predictable and more reliable than I've seen in other devices. And not only does that mean that we're going to get very good treatments, but it also means that we can be very safe. We don't have to worry about an unexpectedly large ablation zone taking out a vulnerable structure, because we can rely on the device to deliver what we've asked it to do. I've worked extensively with planning and fusion software mostly that has been with ablation confirmation to tell us at the end of the procedure whether or not we have done an effective ablation. You can also use that software for confirming where your probe has been placed, but the planning component of the software, being able to do that at the time of the procedure, is a new thing for me. And it's become very clear to me how that integration of the whole process at one point in time is improving our clinical procedures. The planning component of my ablation guide means that we can predetermine exactly what we want the endpoint to look at. So we can decide where the needle is going to be placed and how big the ablation zone is going to need to be in order to treat the tumor effectively. One of the things I really like about it is because you've set out at the beginning what you intend to do, you are responsible for achieving that all the way through, and the software will help keep you online. So however you choose to place your probe, whether it's with robotics, whether it's with lasers, whether it's with CT guidance or just doing it manually, you can then refer back to the plan and say, did I put the needle where I expected it to be? And if you didn't, your choice is either to move the needle where it should have been or to adjust your plan and say, well, okay, if the needle stays there and I do my ablation, do I need to have a slightly bigger ablation zone, or am I simply not going to be able to get an effective treatment there? So being able to do that process at the start of the procedure makes you accountable for the rest of the work that goes ahead. And that's really been an impressive part of my ablation guide to me. The IntelliBlate system and my ablation guide are making me more confident with ablation. I feel like it's now a much more predictable tool with more accountability for myself as the operator throughout the procedure. I think what it's really changed for me is that I can now finally see that we may have an integrated process that is going to be reproducible almost wherever you take it to. If you're able to use this software and you're able to use this device and you do it to the way that it's prescribed with the outcomes at the end that we think warrant technical success, you should be able to achieve the same oncological outcomes as the published data from the larger academic centers. I think we're almost at the future. I think this fully integrated intelligent systems where we can begin to import AI-assisted planning with perhaps robotic navigation or laser guidance and real-time planning and real-time confirmation, all within this kind of closed-loop environment, is exactly where we needed it to get to. I remember 10 or 12 years ago when we first decided to try and use a little bit of software to see if it could help prove where we'd placed the needle or where the ablation zone had ended up. And now, 10 years later, we've got something to looks like the complete package.